Good morning, everyone. Good morning. Thank you. That's a better response. So my name is Dr. Tsitsi Apollo. I'm from the Zimbabwe Ministry of Health and Child Care. I'm the Deputy Director for HIV/AIDS and STIs. Today, I'm privileged to co-chair this session. It's an important session on DSD, Differentiated Service Delivery Models. And I'm privileged to be co-chairing with my colleague, Dr. Nomti from Eswatini. She's going to introduce herself shortly. So basically, differentiated service delivery models, they seek to provide services that are tailored to the preferences, to the expectations, to the needs of the clients. And they put the client at the center of everything that we deliver in terms of service delivery. So they're client-centric. So here we have a panel, this esteemed panel of colleagues that are going to present DSD models from different contexts, different continents. These models target different types of patients, of clients. And it's important to note that DSDs, while they are patient-centric, while they focus on the needs of the patient, we also consider the health outcomes, the treatment outcomes of these patients, of the clients, of the patients. While at the same time, we look at health systems issues to ensure that we alleviate those unnecessary burdens within the health system. We know that in most of our programs, the health systems are overburdened they have constrained health workforce, and while at the same time funding is also a constraint. So we need to find ways of alleviating those burdens so that the health workforce can focus their thrust on those clients that really need those services. So we've got my colleague here. I want to hand over to my colleague who's going to introduce the speakers.
Thank you, Tsitsi. Good morning, everyone. Welcome to this session. As mentioned, I'm Dr. Lukele from the Kingdom of Swaziland. I'm the National ART Coordinator there. So we're looking forward to the presentations that will be here, and I'm sure you'll find them very interesting. One key thing to keep in mind as we listen is that the key elements of differentiated care, which is paying attention to the what is in the package, how is it going, is it being delivered, when and by who. So we have 6 panelists here with us. Each of them will present for 10 minutes. After the 10 minutes, we will have 5 minutes of discussion. Depending on how we do with time, we will continue the discussion after the presentation. So at this point in time, I would like us to welcome Dr. Tamrat Asife, who is a public health specialist with teaching and public health practice experience extending for more than 20 years. He published different papers in peer-reviewed journals as lead and co-author. He received MPH in Health Systems Management and Policy from ITM Belgium University. He also earned MPH from AAU. So over to you, Tamrat.
Thank you. So thank you. Good morning again. So I'm going to present implementation of appointment-specific model of differentiated care in Ethiopia, the success and challenges. So my co-authors, this is a work of Federal Ministry of Health Ethiopia, ICAP in Ethiopia, and also ICAP New York from Columbia University. So Ethiopia is located in the Horn of Africa, the second populous country in Africa, second to Nigeria, with a population of more than 100 million. The existence of HIV in Ethiopia was first recognized in 1980s after 2 AIDS patients were reported in 1986. Since then, the HIV epidemic is growing until recently. So the current HIV prevalence is 0.9. This varies in regions and population groups. And among these, people living with on ART are estimated around 400,000. So why do you need a differentiated care model in Ethiopia? The first one will be the scale of ART. The ART in Ethiopia started in 2003, and the government launched free ART in 2005. Since then, a growing number of clients are put on ART. With the current number, that's 436,000 people are on ART, and this is pressurizing or creating demand in the side of the healthcare service delivery. So the scale of ART in Ethiopia is producing pressure on the healthcare providers. The other reason is the quality of services. As you can see, we are not reaching yet the first, and second, and third 90. So we have gaps in 21% on the first 90, 13% on the second 90. That's putting people on ART, and also the viral load coverage. Thus, we have 49% gap. So we need to reach this gap, and the current strategy is not helping us, to reach this. So we need a differentiated service delivery model. The other reasons are equity and access to those who we are not reaching, and also the burden on the health system in terms of, the human resource. With shortage of human resource in Ethiopia, in the health facilities, and also we need also to consider the cost of clients on one side for traveling, and also their time, to save their time, and also on the health system also. So considering all these reasons, the different service model is now being considered in Ethiopia. So now the key policy questions are which differentiated service model will be considered in Ethiopia to be implemented, or which one should be prioritized. So after considering different reasons, the level of knowledge of comprehensive HIV knowledge in the community, stigma and discrimination, again being considered, and the social-cultural context, then the facility-based spacing model is considered in Ethiopia for implementation. First being piloted in 6 hospitals, and then scale up. So appointment spacing in Ethiopia is selected for stable adult patients. So they'll be offered a 6-month clinical visits, and also a 6-month ART package refill. So stable patients are defined as those on ART for at least 1 year, those with no adverse drug reactions, good understanding of lifelong adherence, evidence of treatment success like viral load, 2 consecutive viral load measures of less than 1,000, and also in the absence of viral load, CD4 or less than counting above 200 cells. So these are the eligibility criteria as stable clients. So I'll proceed to how we implemented. So to show the process, after consideration of this model at the Federal Ministry of Health, a technical working group was established. The people living with HIV association were invited to be part of the technical working group. So this is the NEP Plus in Ethiopia, and also the NEP is the women people living with HIV. Both are actively engaged in this process. So there was a need to revise the guideline, and a supplemental guideline for appointment spacing was developed. Training materials, job aids, and also patient education materials were developed. Initially, the baseline assessment was done in the 6 pilot hospitals. The 6 pilot hospitals are located in 6 regions: in Tigray, in Amhara, that was Dasi Hospital; in Tigray, Mekelle Hospital; in Reda, Dilchora Hospital; in Oromia, Naqamt Hospital; in South, Hawassa Referral Hospital; and in Addis Ababa, the Zawdit Hospital. So baseline assessment was done in these hospitals. Drug quantification was done. Estimation for 18 months was developed by the Pharmaceutical Supply Agency and processed. MND system was also developed because the existing MND system will not help us to monitor the appointment spacing model. Orientation for healthcare providers, facility managers, and also for case managers was provided. The tools developed, provided, and the implementation started. So Ethiopia also joined the CQ program, that's the Coverage, Quality, and Impact Network. This is in ICAP and supported by Gates Foundation. So being a member of this network, the country has benefited a lot in terms of experience from different countries who are implementing different modules. These are some of the job aids and resources developed. Protocol for provisional appointment spacing model at a facility. Provider support tools like eligibility criteria was posted. Classification tool was also developed as a wall chart, and also a form of classification tool was also developed, and this is filled and inserted in the chart of clients. Those are stable clients. Register and reporting formats were also developed. So the service, considering the what, who, and where categories, stable clients or category 4 given appointment spacing for 6 months for clinical follow-up and medication refill at the same time. They are also provider support on medication storage techniques because they are taking 6 months package to their home. So continuous education and communication with peers was arranged. Adherence support was also arranged. Clients receiving treatment as a couple also included or enrolled in this program. As on the first visit, they will be both seen, and then one of them will be provided for 6 months treatment, and the other will be appointed for after 3 months. So since then, they will be they'll come for the visit alternatively. So the MND framework is showing us that the monitoring indicators, these are baseline indicators, process indicators, and outcome indicators, and also the evaluation on process evaluation and outcome evaluation indicators were developed to see or to assess the outcome of the pilot program. Enrollment, so far, from April 2017 to June 2018, about 9,613 clients were enrolled. This is 70% of the eligible clients in the 6 facilities. Among the total eligible clients, a quarter of patients who are eligible has declined. So they are on continuous adherence process. This is to show the trend of enrollment in this same period from April to June. Then the government has launched scale-up of appointment spacing model in July 2017. Since then, the facilities from the 6 pilot facilities, it has grown to reach nearly 1,000 facilities, and the number of clients has grown from 3,000 to from 9,000 to 100,000. So what are the lessons? A rapid enrollment of large number of clients within a short period across different hospitals. More than 2/3 of those eligible have already been enrolled in the program. The reasons for declining is, inadvertent disclosure due to having a storage, and the other is concern regarding safety and storage. In conclusion, differential service model of ACM successfully implemented in Ethiopia. Scale-up required engagement at all levels, as well as resources of planning, implementation. This is resource intensive. There is also a need for formative research to assess clients who are declined from the program, and continuous counseling support and intensive monitoring and evaluation program is should be in place. So this is, we acknowledge the different stakes in the program. Thank you.
Thank you, Tamrat, for sharing the Ethiopia experience. I will open up the floor for questions of clarification, 1 or 2. Thank you. Yes, you can go ahead on mic 5.
Thanks. Nancy Padian from Berkeley. Great presentation. 2 quick questions. One is, with regard to the peer support, I was wondering if you standardized that and what the peer support looked like, both in the pilot and then in the scale-up. And then the second question is, I assume that you made the decision to scale up because you had data from the pilot to indicate that it was an effective model. And I just was kind of wondering about that decision point.
Thank you. I'll take the next question still on mic 5.
That's okay. Hello, Sam Perry from Malawi. Thanks for the presentation. I just wondered if you can just elaborate, for example, after you've looked at a successful scaling up of the model, have you looked at the outcomes of the cohort just to look at how the outcome data compare to the other models, for example, retention, viral suppression, and others? Thank you.
Yes, you can go ahead on mic 4.
Jean-Baptiste Guillard-Schmidt from Burkina Faso. Why did you choose this specific DSD model rather than a panel of different DSD model, or rather another one? And what are the step forward for the implementation of the DSD in Ethiopia?
Thank you for the questions. I will respond on the sequence. The first one is standardizing the peer support. So facility-based adherence group was being established in each facility. So people enrolled in ACM will be also enrolled in the adherence support group in the facility, so that they will have a discussion when they come for the refill every 6 months. The second one is the decision to scale. It didn't happen to. It came before the evaluation of the pilot program. It's not after the evaluation. So once we started the pilot, it's an ongoing process. Then the government wanted to scale before we conclude or we evaluate the pilot program. So there is an overlap. We didn't see the outcome measures because this is now in the beginning stage, and we are waiting for 18 months to start to evaluate the outcome. And why appointment spacing? This, as I said before, to relieve the burden from the health facility, and this is appropriate to be implemented at a larger scale. So now it's being implemented in 1,000 facilities. So relieving the healthcare providers and relieving the system so that they will take their time for other clients who need more intensive support than the stable patients. Thank you.
Thank you. We move on to the next presenter, who is Frank Chirowa, a public health specialist and a health economist with interest on costing and interventions of HIV/AIDS delivery. He's going to present a comparison of patient cost and distance to access care through differentiated models of antiretroviral treatment delivery in Zimbabwe. Thank you.
Okay, thank you for the introduction. I'll move straight into the presentation entitled Patient Costs of Accessing Care at Health Facilities versus Community-Based Art Delivery Models. Maybe just to get the audience to speed to the work, I'm going to give a sort of a brief historical background that this work is part of an ongoing study that is taking part in Zimbabwe. The study is actually called Cost Outcomes of Differentiated Models of Art Delivery. Where we are comparing art delivery 3 months within the facility, which happens to be the control arm, and 2 intervention arms. We'll be providing 3 months art in the facility, as well as 6 months art in the, 3 months in the CAGs, and as well as 6 months in the CAGs. So the work that I'm presenting to you now is just but one of the objectives of the main study that is taking place in Zimbabwe. So as of background, Zimbabwe has an estimated 1.3 million people living with HIV and AIDS, of which 84% of them are on treatment. And then for the patients to be retained on treatment, ensuring that they have access to antiretroviral drugs, they have to grapple with a couple of barriers, which include distance, time to the facility, travel costs, as well as other competing activities that could hinder them from accessing care, especially for rural patients. And one of the DSD models to sort of ameliorate that is the community art referral groups, which is one of the many models, but we chose to use the community art referral groups to sort of analyze how best it sort of benefits and solves the patient barriers. And then specifically, an analysis of the patient baseline costs comparing the CAGs and facilities was done. And then in terms of methods, the framework that you see there is basically the design for the study that alluded to earlier on, and it has got the control arm there where we are providing 3 months supply within the facility, and then the 2 intervention arms that we have lumped as community. And then in terms of where exactly this study is taking place in Zimbabwe, we've put up a map there that is actually showing the geographical provinces in Zimbabwe and the HIV adult prevalence rate. So the study is taking place in the areas that are demarcated by a red triangle, and these are actually 4 provinces and 5 districts. But we actually have 10 provinces in Zimbabwe, and the reason why we zeroed in these provinces because it is the provinces that our funder, USAID, is actually implementing projects in. And then in terms of how we got to the 5 districts, the other criteria that was used was also the availability of newly formed CAGs, because the protocol stipulated that the CAGs had to be new CAGs. And then data was actually collected between July and December by 30 trained study nurses. And the key point to note here is that follow-up data is to be collected and should be repeated at 12 months, which is the midpoint, and also at 24 months, which is the end line for the study. And then a sub-analysis, which is the results that I'm presenting to you now, is I highlighted that we are starting from the main study there where we managed to enroll about 4,882 patients. But from these patients, we did a sub-analysis where we got a sample size of 951 patients where we asked, we administered the patient costing baseline questionnaire. It was an interview-administered questionnaire. And patients from the facility arm were asked the distance to the facility, transport costs, the modes of transport, and the time they were taking to the facility. And the same was done to the patients that eventually chose to be in the CAGs, but you realize that they were asked the same questions, which is capturing the time when they were collecting medicines from the facility. But in addition to that, because they had expectations, the joint CAGs, we also asked them questions about their expected distance to the community meeting place, as well as the transport cost and the time they're likely to take to that community meeting place. And then in terms of results, we found that the average distance to the facility by patients in the facility arm was 9 kilometers one way. But for the patients who eventually joined CAGS, and the time when they were collecting medicines from the facility, they used to travel 7 kilometers one way. But that's expected to be less than 1 kilometer by joining CAGS, that is if the medication is provided within their proximity in the community. And then in terms of time taken to get to the facility for purposes of a pickup, we realized that for patients in the facility arm, no one took less than 30 minutes to get to the facility for the purposes of picking up medicine. But the patients who were in the community arm, also at the time when they were collecting medicines from the facility, you see a zero here. No one also took less than 30 minutes. But from the patients that responded on their expectations when they joined CAGS, about 67% of them highlighted that they'll take less than 30 minutes to get to their community pickup point. So what is the effect of this time reduction? We also did some kind of an analysis of the competing activities, that is, some of the activities that these patients could be doing or that they would forego for them to go and collect medicine for the facility. We actually disaggregated this data by patients in the facility arm and patients in the CAGS arm. And then the message that we are putting across here is that patients that joined CAGS, most of them were into farming, selling of artifacts, gold panning. And then the interesting one here is of patients who had people who would accompany them to go to the facility for the purposes of picking up medicine. But if they were not going there, the people who were accompanying them were supposed to be in school. So we are saying by using the CAGS as a method of distributing the drugs within the community, some of these competing activities which sort of mimic the livelihood, the sources of livelihoods for the patients who are living with HIV could still be done, as one person could go to the facility and collect medicines on behalf of a group. And then in terms of transport costs to the health facility, from the facility arm, we found out that the average cost to get to the facility two-way was around $3.78. And then it's almost the same for the patients who chose to be in CAGS, but this is the amount that they used to get to the facility before CAGS. But by joining CAGS, this amount is expected to reduce to around $1.80. And this is because that mostly the community distribution is either within the walking distance of the patients, and they will not use like transport to get there. And for the few that will be using transport, it will be like sort of reduced. And then in terms of modes of transport to get to the clinic, we sort of again disaggregated this by urban and rural patients. So we found out that the bus and taxi, which is the only paid method, was also being used, bicycles, scotch cart, walking, and own transport. But the interesting picture is that we tried also to find whether there was a significant difference in the use of the bus between the rural and urban patients. So we see that it was significant at 1% there. And what it's saying there is the urban patients really rely on paid mode of transport as compared to the rural patients. And then the reverse is true in terms of walking, where the rural patients heavily rely on walking as compared to the urban patients. So what we are putting across here is to say if people join community art refill groups or other differentiated models of art delivery within the community, there's likely to be a reduction in cost, and as well as the reduction in distance that's for both the rural and urban patients. In conclusion, CAG members expect to travel shorter distance with reduced travel time, as well as reduced transport costs, and also that the other competing activities can still be done as people can send one person to go to the group. And then lastly, a comparison of the patient costing baseline data with the actual 12 months and 24 months follow-up is critical for us to get sort of the actual benefits for the CAGs, because now we're presenting the expected costs. And then in terms of limitations of the study, the reported transport costs and distance to CAG meeting places are not actual, but expected costs and distance are obtained from new CAG members. And then also that the sample size was not reached. It would be good to sort of, if this study is replicated somewhere else with a larger sample size. Thank you.
Thank you, Frank, for the presentation. We'll open up to the floor for questions or points of clarification. I request that you ask that one area that you feel needs to be clarified or addressed. Yes, in mic number 5, you go ahead.
Yeah, what recommendations for changes would you make to the CARG program based on your data looking forward?
Sorry, if I got the question correct, are you saying any changes that we made to the CAGs based on the data?
Yeah, recommendations moving forward on CARG based on your data and results.
Okay, can we take the second one on number 5?
Thank you for the presentation. This is Amobionovo from Nigeria. I would just like if you could clarify a bit concerning your target beneficiaries, if they included key population. And what do you think would be the implication of this model, the CAG's approach for key population? Thank you.
The last question, I think the others will take at the end if we have time. Thank
so,
you.
Just is there any sense of any groups that are left out? So obviously some groups really liked it, but are there any particular groups that are obviously being left out or don't use it?
Thank you for the questions. I think I'll start with the first one that asked whether we made any changes programmatically in terms of the results that we got. So these are the preliminary findings. As I highlighted, these are a baseline. So it's part of a major study that we are doing that we seek to conclude. And after we have done that, when we follow up 12 months after, we're able to come up with actual costs that we compare with CAGs, and that will be able to help us inform policy as well. And then with regards to groups that were left out, so this, we didn't include key populations, though there was some outcry in terms of some groups willing to be involved in CAGs, but it's something that's new, something that we are still generating evidence. We even found also that even mobile migrant populations were saying, yeah, sort of leaving us out. We want something that is similar to this. Thank you.
Thank you. I think we can move ahead with the next speaker.
Okay, thank you.
Thank you very much. I would like to introduce our next speaker, who's Claire Barrington, who is an associate professor in the Department of Health Behavior at the University of North Carolina, Gillings School of Global Public Health. She conducts mixed methods research on social network and structural influences on HIV prevention and care with key populations in Latin America.
Thank you very much, and thank you all for being here today on this last panel of the conference, or one of the last. I'm thrilled to be presenting work from the Central American region on this panel and contributing to this important conversation about differentiated and, in our case, decentralized care. And I'd like to acknowledge my colleagues from UNC, from the Universidad del Valle de Guatemala, our partner in Guatemala, from CDC, PEPFAR, the Ministry of Health, and the Roosevelt Hospital in Guatemala City. We'd like to dedicate this presentation to our colleague, Dr. Carlos Mejia, who was the director of the centralized clinic that we worked with, who was murdered just over a year ago during the course of this study, and he was a true pioneer of Guatemala's response to HIV, and was a victim to the senseless violence that affects Guatemalans every day. Guatemala is a Central American country that has a concentrated HIV epidemic that disproportionately affects men who have sex with men. In our formative and past research in this setting, we've identified that barriers to retention in HIV care include HIV clinic dynamics, both structural and social, and also limited economic opportunities, employment opportunities, which impact economic stability. On a contextual level, HIV care and treatment are highly centralized in Guatemala. In Guatemala City, when we started this study, there were only 3 sites where HIV care and treatment could be obtained. So centralization of HIV care and treatment can negatively impact access, quality, and cost of care. And in discussions of decentralization, there's 2 main models that have been used. The first is partial, where you start receiving care in a hospital or tertiary level facility and then transfer to primary care. The second is complete decentralization, where you initiate care in a primary care level facility, perhaps even at the point of diagnosis. Both partial and complete decentralization have been found to improve retention in HIV care. And as we started this study, decentralization was the framework that we were using, but in the course of doing the work, we have also integrated this framework of differentiated care and responding and adapting to the needs and preferences of particular subgroups of clients. So we're really looking to integrate decentralization and differentiation in this work. The purpose of this study was to determine acceptability, satisfaction, and HIV outcomes with decentralized and differentiated HIV care and treatment for men who have sex with men in Guatemala City. This is part of a key population implementation science initiative sponsored by PEPFAR and CDC, and we started the study in January 2017 and just finished our end-line data collection in June of 2018. We began with a process of formative research to inform our approach to decentralization and differentiation of services, and identified key points of action and consideration in terms of location, timing, and just the time burden of getting care in general. All of the participants in our study were recruited at the Roosevelt Hospital Infectious Disease Clinic, which is the largest HIV care providing facility in Guatemala and has over 4,000 patients. And the key characteristics of our population is that they were stable patients, which was defined as having been enrolled in care for over or at least 1 year without interruption, having a viral load of fewer than 1,000, and being on first-line treatment. And the reason for using this was that since we were going to be decentralizing people to new facilities, we wanted everybody who entered the study to be in a stable place when they started. So we used a voluntary partial decentralization model to 3 key population-friendly clinics within Guatemala City that are located with their logos there on the map. The first was Fundación Marco Antonio, which is an NGO with a long history of providing HIV prevention and care services, and is located in a major market and transport hub. The second was Colectivo Amigos contra el SIDA, known as CAS, which is a gay men's health and rights NGO located close to the city center. And the third was a public STI clinic called the Zone 3 Clinic, sponsored by the Guatemalan government. And all 3 of these clinics are part of the Visits Initiative, which is an integrated STI surveillance, prevention, and care program that's been implemented for many years now in Guatemala. In addition to decentralization, we also incorporated aspects of differentiation, including offering care on distinct days than what was offered in the centralized facility and in distinct hours. So across the different clinics that participated, people could get care on Saturdays and Sundays and in the evenings. Another innovative part of our project was that we integrated a bidirectional capacity building process between providers from the centralized HIV facility and providers at the STI clinics that we were decentralizing to. So our goal with that was for HIV providers to increase their capacity for STI treatment, and for the STI providers to increase their capacity for HIV care and treatment. Other intervention components that were offered to all participants in the study included navigation to provide accompaniment, support, and advocacy, in particular as participants decentralized, and mHealth appointment reminders. We used a mixed methods evaluation, including structured surveys at baseline and 12 months of follow-up, a longitudinal in-depth qualitative sub-cohort with 20 participants who we interviewed at baseline 6 months and 12 months to evaluate the experiences, more of the process and mechanisms of what was going on as they decentralized, and clinical chart review every 3 months. The three principal outcomes that we're looking at are retention and care, which we've measured as attendance at scheduled HIV clinics every 3 months, adherence, and viral load. And for our analysis, we've integrated aspects of thematic qualitative analysis, descriptive statistics, and bivariate analysis at this point to describe and assess indicators and processes related to acceptability and retention and care in our decentralized model. The main point from this very number-heavy slide is just to show that this was not an RCT, but we were fortunate that the individuals who opted to decentralize and those who did not ended up having very similar characteristics with no significant differences. The median age of our population is 33 years and had been living with HIV for approximately 4 years. About half of participants had secondary education or less. And as I mentioned before, they were all stable patients who were adherent and stable in care. So now to get into the results, among the 258 eligible participants who were recruited for the study, 46% accepted the voluntary offer to decentralize and 54% chose to stay at the centralized clinic. This was the first main question of our study. We had no idea if anybody was going to agree to decentralize, if they would want to stay. And so this was the first sort of input that we got. And you can see in the table that about half opted to go to CAS, the Gay Men's Health and Rights NGO, 41% to the Fundación Marco Antonio, and then 8% to the government clinic. The main reasons for accepting decentralization were location, and location was both relevant in terms of where people worked and where they lived. As one participant said, it's closer, not so close to my house, but rather it's an ideal location that I can get to easily and quickly. So that was another important lesson learned for us, that location mattered not just in terms of where people lived. Individuals also expressed that they opted to decentralize to one of the particular clinics in our study because they had been diagnosed there or had some personal previous experience that was positive there. Similarly, some participants didn't have experience but had positive perceptions or had heard good things. And then some people had an altruistic desire to help advance the science of HIV care implementation and were motivated to help our initiative for that altruistic reason. It's important to note that some people, over half of the sample, opted not to decentralize. And one participant articulated his reasons saying, well, I can tell you that transferring to another clinic, I feel that would be really different, a big change in my life, and it will take me a while to join. In terms of outcomes, we were looking for everybody to stay stable through this decentralization process. And so 98% of all of the decentralized participants attended all 3 appointments during the study period, so they were retained in care. And we found that decentralized participants, as well as centralized, stayed adherent to ART and maintained the same levels of viral load throughout the course of the study. So our goal here was for everything to stay the same, and essentially it did. At the decentralized clinic, 94% of participants considered overall quality of care to be excellent. A major finding was that the median duration of clinic visits was 33 minutes compared to the 4 to 5 hours or whole day that people had to spend at the centralized clinic. Health navigators were identified as being highly valued as people transitioned to these new clinics, and they appreciated having somebody looking out for them and accompanying them in that process. And overall, participants had an integrated appreciation for location, time, and quality. So it was those 3 factors really came out in narratives of what decentralization had meant to them. And one said, we hope that this project continues, since due to my work, I can only go on the weekends. Also, we get great personalized care and don't have to wait that long. In conclusion, decentralization was acceptable to almost half of the sample, and others indicated during the course of the study that as they heard their colleagues and friends talk about decentralization, they were interested in exploring this option as well. HIV care and treatment outcomes were sustained, and decentralized participants were highly satisfied with this integrated combination of time, location, and quality of care that they got at the 3 decentralized clinics. Findings support continuing and extending decentralization to create more sustainable, convenient, high-quality HIV care and treatment options for MSM and other populations in Guatemala. Thank you very much.
Thank you very much, Claire, for that clear presentation. I will open the floor for questions and answers. Maybe I could start.
Okay.
So, Claire, in terms of the findings, almost half of the clients opted to be decentralized. Was it something that you were expecting?
We really didn't know. This was sort of a huge moment of decision in the study that everything was contingent on getting about half of the sample voluntarily choosing to decentralize, but we really didn't know what people would choose. So it was a pleasant surprise for us, but not something that we really knew how it would play out when we started, which is part of the sort of more implementation science aspect of this work, and some of the unknowns that we knew we would have to adapt to as we went on.
And what are the implications of the study findings to the national program?
So the plan is in Guatemala, the Ministry of Health, with support from CDC, is working on scaling up decentralization throughout the country and also in other countries in the Central American region. So these data are providing sort of the first evidence that that we're not seeing any negative impacts and that it seems that people can sustain and be stable. And I think next steps would be to think about, as opposed to a partial decentralization model, how could complete decentralization happen? So for example, if somebody got diagnosed at one of the NGO clinics that is in the decentralization model, they could just stay there and be receiving care, which has just not been the traditional approach in Guatemala to date.
Okay, there's someone at at mic number 7. Can you speak?
Thank you very much. I'm Rajotte from Cambodia. Thank you for sharing your result. I just also wish to share the challenge we face for the decentralization in our center. We found we wish to decentralize them to get the treatment near their home. But the issue is that because the client themselves found that our center is more friendly than the clinic near their home, then we face the challenge that even we want to send them, but they don't want to go back. Yeah. So I think if we wish to decentralize to their near home clinic, the services should be comparable to the previous clinic. Then the client will be more accepted to be transferred. Thank you.
Absolutely, I agree, and I think it's important to note that the level of satisfaction amongst decentralized participants in this study speaks to your comment and echoes the sentiment that people need to feel positive about the care that they're getting.
Okay, we'll take one more. Mic number 5.
What are some barriers to accessing care that aren't addressed by decentralization?
I think it's a great question. I don't know that we haven't been able to dig into some of those issues that I know will come out in our qualitative data in particular as people speak to what their experience has been. But decentralization, I think, is helping with some of the cost and time factors in particular, but it doesn't solve one major issue that is affecting our population that we've heard a lot about, which is sustaining stable employment and being able to maintain economic productivity. That's already a challenge for gay and bisexual and other men who have sex with men in Guatemala prior to HIV. And so I think that structural issue of being able to sustain themselves with employment while living with HIV has continued to threaten people's ability, even in a decentralized model, to stay in care and stay well. So that's a definite issue that this model is not comprehensively getting at, though it helps, I think, by offering care that is more convenient and potentially more easy to sustain.
All right, thank you very much, Claire, for your presentation and the responses. I would like to introduce the next speaker, who is Monica Roy. Monica is an assistant professor in the Division of HIV, Infectious Diseases, and Global Medicine at the University of California, San Francisco. She's going to make a presentation on urban adherence clubs in Zambia.
Good morning, or rather almost good afternoon. Honored to be here today, and it's my pleasure to be here presenting on behalf of the Community ART Study Investigation Team. Urban adherence clubs are a DSD model which provide off-hours facility access and group drug distribution with the aim of improving on-time drug pickup and retention and providing greater patient-centered care. While the successes during scale-up of UACs in South Africa have been widely reported, there have also been some recent reports of high loss to follow-up and transfers back to facility-based care, leaving some to question if the UAC model is truly the success story that it has initially appeared to be. An additional limitation of the existing literature is that all published evaluations have been limited to observational analyses, which are subject to selection bias. This led us to conduct the Community ART study, in which we sought to evaluate the implementation and effects of urban adherence clubs in Zambia using a randomized study design. We pair-matched urban clinics in 3 provinces in Zambia based on province, clinic size, and retention. 5 of these pairs were selected, and then within each pair, we randomized one to receive the intervention and the other the control. At both intervention and control facilities, eligibility was assessed using the following criteria: adolescents and adults on ART greater than 6 months, last CD4 count greater than 200, and not acutely ill as assessed by the clinical provider. A systematic sample of eligible patients were then offered the UAC intervention. Patients at intervention clinics received the intervention while control patients received the standard of care. Of note, the intervention was randomized and implemented at the clinic level, but was analyzed, as I will discuss in a moment, at the individual level. So what exactly is the UAC intervention? Essentially, it's a group-based multi-month refill program. In urban adherence clubs, or UACs, a group of 30 stable HIV patients from the same community meet together in the off hours at the facility to receive adherence support, symptom screening, and drug dispensation every 2 to 3 months by a pharmacy technologist and a peer health worker. Patients come to the clinic during regular hours only once every 6 months for clinical monitoring and lab work. Our study measurements included use of the pre-existing National Medical Record System, SmartCare, a group meeting attendance register, a departure log, qualitative interviews and focus groups, and active outcome ascertainment at the end of the study period. Our primary outcome was patient retention and care, defined as first missed drug pickup greater than 7 days late at 12 months. We constructed Kaplan-Meier curves and a mixed effects logistic regression model with clinic and group as random effects. Our secondary outcomes included alternative metrics of retention and implementation outcomes, including acceptability, adoption, feasibility, and fidelity. These outcomes were analyzed using descriptive statistics and qualitative data analysis. There were 594 patients enrolled in the intervention group and 502 in the control. Baseline characteristics are shown here, and you can see that patients were similar in terms of sex, age, enrollment WHO stage, CD4 count, and time since ART initiation. They were also similar with regards to various baseline metrics of retention, including the medication possession ratio, which is the proportion of time patients are estimated to be in possession of their drugs based on pharmacy visit data, as well as late drug pickup. Here are our primary outcome results. The cumulative incidence of the first missed drug pickup, defined as 7 days late, was significantly higher in the controls compared to the intervention participants, 58% versus 29%. Similar results are seen when using a more conservative measure of 28 days late. Here are the preliminary results of our mixed effects regression model. We pursued modeling as a more rigorous approach, both to address confounding for any imperfections in randomization, as well as to account for clustering at the clinic and group level. As you can see here, the two things that remain significant in both the unadjusted and adjusted model were control and sex, with an odds ratio, an adjusted odds ratio of the control and intervention of 4.22, indicating that the intervention was effective in reducing odds of having experienced a late drug pickup at 1 year. In addition to evaluating effectiveness, we sought to study the implementation of UACs, beginning with adoption of the intervention. In this graph, you can see that there was initially high adoption of UACs, with almost everyone who was offered the intervention accepting it. Although placing patients into groups was easy, linkage to the first meeting was a little challenging, as evidenced by the first drop in the cascade. Many of these patients subsequently did get linked into the group, thus that explains the rise in the following step. Finally, interestingly, of the 597 patients who were originally offered the intervention, only 40% made it to the end where they actually joined a UAC and attended all meetings. To elaborate on this last point further, you can see here more about the people who missed UAC visits, and that they weren't just limited to a small group. Since only 40% attended all visits, conversely, of course, the majority, 60%, missed at least one, and 1/3 of patients missed 2 or more visits. We then dug into the data further to understand how we could see such strong effectiveness results, recall those Kaplan-Meier curves, but have some fair amount of lack of attendance at meetings. Here you can see that of 3,874 total visits made, 83% were attended, that's moving to the left, and 17% were not, the first branch to the right. Of the UAC group meeting visits that were missed, roughly 1/3, or 32%, still resulted in same-day drug pickup. Now, this occurred either via a buddy who came to the UAC meeting or patients themselves coming to the clinic that same day but outside of the meeting. Now, amongst the group of patients that didn't have same-day drug pickup, 1/4 still returned on their own within 7 days of the clinic to pick up drugs. As a result of the 785 unattended visits, drug pickup within 7 days still occurred in almost half of those visits. So let's look in a little bit more detail at those visits in which same-day drug pickup didn't occur. So we were interested in understanding how long it took. So I just mentioned to you that roughly 1/4 of patients did come within the first 7 days. We also looked at intervals beyond that. So at 14 days, 36% had returned, and at 28 days, 45% had returned. And this in part helps us to understand why, despite some lackluster UAC meeting adherence, the intervention itself was found to be effective. Patients were able to, what we like to call, recover from a missed visit and still come back to the clinic and get their medications before significant delays occurred. In addition to meeting attendance and drug pickup, we also looked at migration out of UACs. On the left are the reasons patients left a UAC within the 12 months of follow-up, and on the right is the time from enrollment to the day of departure, which, as you can see, occurred steadily after the first 100 days. Reasons from departure from UAC were varied, ranging from changes in clinical status, such as pregnancy and diagnosis of TB, to patient preference. Finally, in order to further characterize adoption as well as acceptability and feasibility, we conducted qualitative interviews and focus groups. Highlights of this data are included on this slide. First, healthcare workers were concerned about requirements of pharmacy technologists to work off hours and to spend additional time pre-packaging medications. UAGs were considered acceptable to healthcare workers as they were perceived as being a means to decongest clinics. However, healthcare workers felt that success would depend on further investment in human resources and, to a lesser extent, infrastructure. From the patient perspective, the timing of drug collection in UACs was particularly well suited for patients who worked and couldn't come to clinic during the day. Group size and mixed gender groups, which we were concerned about, was found to be actually quite acceptable. ART delivery through groups was seen as enabling information sharing and peer support. A quote from one of the focus groups nicely highlights this point. "At least now I am able to talk with my friends in the UAG. I am able to know people now. In fact, I am free. I feel like now the UAG is my family." Lastly, inadvertent disclosure was not reported as an issue, and in fact, concerns about stigma decreased as patients were no longer seen visiting the clinic during regular hours. There were several limitations to our study. From the design perspective, we were limited by the number of clinics and the number of groups within clinics that we had resources and funding to support. In addition, we are not yet able to evaluate the sustainability of the intervention, as our current outcomes are reported only for 12 months. We hope to utilize the existing EMR system to assess outcomes at longer periods of time, such as 24 months. From a measurement perspective, we've had challenges with missing data in the EMR, which led us to manually review charts and enter missing data. And finally, viral load testing is currently in progress and has not yet been reported and is not reported today. In conclusion, we found that 12-month cumulative incidence of first missed drug pickup was significantly lower in the intervention group compared to the controls. We also found that UACs were acceptable, feasible, and initially highly adoptable. Over time, the majority of patients missed at least one visit, but recovery, meaning drug pickup within 7 days of that missed visit, occurred in almost half of all unattended visits. Lastly, migration out of UACs was noted to be multifactorial and related to both changes in clinical status as well as patient preference. Our findings have several important implications. First, UACs are an effective tool in the DSD toolbox to reduce late drug pickup and time out of care. The choice of a UAC-type model, essentially a group-based multi-month refill model, needs to be considered amongst other effective DSD models. However, a key question still remains, is when to use which model. Based on some of our findings, particularly our qualitative data, clinics that have a relatively greater problem with space over healthcare worker resources may be the ideal setup and situation for UACs. Importantly, given the frequency of missed UAC meetings and frequent alternative means of drug pickup, DSD models need to be flexible and patient-centered if they are going to successfully improve retention. And finally, successful monitoring and evaluation of UAC programs and other DSD models will need to account for frequent migration into and out of the model. I'd like to thank the Zambian Ministry of Health, our participating patients and healthcare workers, as well as the Bill and Melinda Gates Foundation for their funding support.
Thank you very much, Monica. We'll open the floor for discussion. Mic number 5.
Stanley Way, U.S. CDC Mozambique office. It occurred to me that your intervention seemed to kind of combine two good things. You have the adherence club aspect of it and also the evening availability of drug distribution aspect. And it seemed to me you could have used those same resources just to have the pharmacist available in the evening. So I wonder what your thoughts are about whether that would be a good way to go or whether the adherence club aspect was truly crucial to the success.
Okay, we'll take microphone number 3.
My name is Ochagbaji from Nigeria. Thank you very much. A very good study. I just want to find out what kind of method did you use to track these patients that didn't come back? And then did you offer any kind of incentives to the patients or to the staff in light of sustainability? Thank you.
Okay, we'll have responses. Unfortunately, if we have time, we can take questions at the end.
Thanks. So I think if I understood the first question, it was related to the fact that there's potentially multiple mechanisms of the intervention effect, one of them being social support and the other being kind of increased access to the facility. And to some extent kind of trying to understand which of those is more important or maybe kind of the driving factor. And I think, we have not quantitatively set our study up to look at that. I think we've certainly demonstrated with this model as well as other models in Zambia, there's likely multiple mechanisms of effect. And I think potentially looking at that, kind of breaking that down in the future would be very helpful, I think, especially when resources are limited. I think one other point I would make about that is in Zambia, at the same time that we rolled out urban adherence clubs, multi-month refills without the added element of social support was ongoing as well, and data from that was presented at this IAS conference. So I think that there's potentially, multiple effective interventions that include kind of some of these components, if not all. But I think it would be very important and interesting to look at, break that down further. And then in terms of how did we track patients and any money or contributions given to the staff. So we made it actually a very active point that once patients did not come to a meeting visit or a clinical visit, that we did not do kind of active tracing during the study period, because we felt like that would in fact end up then becoming part of the intervention and potentially not a sustainable part of the intervention. So when patients were known to be lost to follow-up, they were referred to the clinic staff who have a standard procedure for after a certain number of months do send out peer workers to trace patients to try to retain them in care. And then in terms of contribution to staff, so this was actually, because this was done more in a study setting, those implemented as pragmatically as possible. We funded the staff. I think we're gaining valuable information currently in Zambia as these DSD models are being rolled out, within the ministry with existing healthcare workers at the sites. And I think that there's a huge amount of motivation from those healthcare workers because they've been able to see the decongestion in clinics and other benefits that have benefited them. So.
Thank you very much, Monica.
Okay, we move ahead with our presentation. Now the next speaker is going to be Joann Frances, an epidemiologist with over 11 years of experience in designing experimental and observational studies, monitoring, evaluation, quantitative data analysis, and systematic reviews and meta-analysis, particularly in the area of HIV and AIDS and alcohol use among people 15 to 24 years. He is currently employed and working at VETS RHI, but will be findings from previous work in Tanzania.
Thank you. Thank you so much. First of all, thank you very much. I thank the organizers for an opportunity to come and present primary outcomes of the study that we carried in Dar es Salaam, Tanzania. And I thank the participants for coming to listen to this presentation. So I'm presenting on behalf of my colleagues who are from different institutions, as shown by the logo, the Management Development for Health in Tanzania, the National AIDS Control Program, and Harvard University and Heidelberg University. The study was funded by the Gates Foundation through 3IE International Initiative for Impact Evaluation. So this study was carried out in Dar es Salaam, Tanzania. Dar es Salaam is the largest city in Tanzania and East Africa, and it harbors most of the HIV-infected patients. So we tested a new mode of care, the ARV deliveries at the community, at the home, or any other place at the community for stable clients. And the stable clients were defined by being on treatment for at least 6 months and having a CD4 of more than 350 and having suppressed viral load. And our main aim was to establish the feasibility, acceptability, and effectiveness of home delivery of ARVs. And so this study, as I said before, was implemented collaboratively by investigators from Management of Health for Health in Dar es Salaam, Tanzania, and Harvard University, in close collaboration with National AIDS Control Program and the municipal authorities who are custodian of the healthcare facilities. And our main primary effective endpoint was the virological failure, and the trial was registered at the United States National Library of Medicine and National Institute for Health clinical trials in the USA. So why did we do this study? So it's clearly that there's an urgent need for increased capacity of ARV or HIV care and treatment delivery due to Apparently, most people are on treatment, and the treatment is successful, they live longer. And then there's ambitious targets globally for HIV-positive individuals, and potentially the public sector ART clinics will be often overcrowded. So alternative means of delivery of services will be an opportunity to offload clients from the overwhelmed clinics. And then the other thing was the home-based care providers is an established cadre in Tanzania, and they're supervised by the NGO MDH, MDH, which is an organization responsible for HIV care and treatment in Dar es Salaam. And then it was an opportunity to use home-based care providers because they are already trained, and for the intervention, we only needed a few short training period to empower them on the approaches required for the delivery of ARVs at home. So why do we choose non-inferiority trial? Our thinking was if ARV community delivery produce the same or better health outcomes compared to the standard of care, then it is a plausible option for people who are stable on treatment and could leverage the healthcare facilities. So our study design was a class randomized trial that involved 48 facilities in Dar es Salaam. These 48 facilities all are managed by the MDH, and all had home-based care providers affiliated with them for delivery, for support of HIV patients who are not able to maybe to come to the clinic for as they are required. And the 48 facilities were randomly 24 facilities among the 48 clinics were randomly selected to participate in the intervention arm, and the other were supposed to continue with the standard of care. And then the intervention arm involved the delivery of ARVs by the trained home-based care provider, supported by a community nurse, and then the home-based care provider was also responsible to provide continued counseling and on adherence to treatment, and also collected information on the basic monitoring and evaluation data that is required by the national program. And the protocol for this trial was published at the BMC Health Services Research Journal. So we carried out a baseline assessment and then end-line assessment for people who were enrolled into the trial. So as part of the intervention, we had to train the home-based care providers and the community nurses on HIV treatment, and essentially mainly on the ARV management. The picture shows some element, a key element of the intervention, whereby the home-based care provider had to consult or to meet with the community nurse to collect ARVs for the clients who were due to receive their ARVs at home. So in total, we recruited 2,000 individuals. Half of those were in the intervention arm and half were in the control arm. And the mean follow-up time was 326 days, approximately 1 year. And 44% of the patients in the intervention arm were eligible for enrollment. And among those who were eligible for enrollment in the trial, 86% we consented to receive ARVs at home. There's a flow diagram which may not be clearly visible, but this shows that there was a balance between the control and intervention arm in the basic characteristics, and then loss of follow-up as well was around 15 and 18% from the control and the intervention arm respectively, and it wasn't statistically different. And we had a total of 3 deaths during the implementation of the study. 2 in the control arm and 1 in the intervention arm, and that the deaths were not related to the intervention. So in terms of analysis, we had intended, our registered primary analysis was intent to treat without adjustment, and we carried out log binomial regression to estimate the risk ratios, but we further conducted secondary analysis to adjust for baseline viral load assays, and also to determine the effects among only those who had suppressed viral load at baseline, and also assess the causal effect using the instrumental variable regression. And so our primary outcome showed that the intervention was not inferior to the standard of care. And our marginal cutoff point was 1.5, and we reached that point, we reached that decision by consulting the experts, but also looking at other studies that were conducted in the region. So we used the reference of a study that was conducted in Uganda, so we reached the decision of upper marginal point of 1.5. So our finding shows that the risk ratio was, the confidence interval lied from 0.9 to 1.2, and that was below the highest cutoff point for inferiority, and that was statistically significant. A little bit more about the results. So the clients were overall very satisfied with the HIV home-based care provider services, and most of them reported to have received the ARVs at home on time. So in summary, the intervention was effective because the results showed that the intervention was not inferior to the standard of care, and it was feasible. ARV community delivery implemented by existing public sector health workers, and then the training of community health workers and community nurses took 3 days. So it's a feasible and easily scalable intervention. And it was also acceptable, as reported back by the clients and also the home-based care providers and the healthcare providers. So what are the next steps? So we are carrying out additional analysis to assess the patients and public sector cost studies, economic evaluation, but also we ask the clients on willingness to pay for the services. So that's something that we are looking at. But we also need to engage the policymakers to be able to take on the findings and maybe implement scale it up at a wider scale. And then overall, the ARV community delivery is a policy option for urban Tanzania, but also in other places in Africa with similar settings, but should be adapted in the local context. But then I think it's also important to do a long-term follow-up of clients who receive ARVs at home, because the medium exposure to the intervention was around 7 months. So at least we need to see if there is any effect of in the long term. And then we managed to recruit only a few clients, 44%, because the trial was limited to clients who lived in a catchment area that was reachable by the home-based care providers. So if there is an opportunity to be able to relax the restriction to catchment area, then we'll be able to recruit more clients, and that would have an impact to offloading the clinics offloading the number of clients who are supposed to come to the clinic. So in this trial, only 4% of the clients attending the intervention clinics have received the ARVs at home. So I would like to appreciate the support from the clients and also from the Dar es Salaam city municipalities, who are the custodian of the health facilities and responsible for delivery of health services, the National AIDS Control Program, our funders, the study teams, and colleagues at the Management Development for Health. Thank you so much.
Thank you, Francis. I can see your presentation has generated some ideas from the floor, but in the interest of time, I will only allow number 2 to ask the question. The rest of us, we can still talk to Francis at the end of the presentation. Thank you.
Thank you very much. I'll be very quick. I'm called Samson Kironde from Uganda. I work with URC. And I'm just wondering how soon you expect, as a result of what you did, to have this translated into actual implementation. I was in Tanzania, I think in Iringa district or Iringa region last year, and we were told that there is no community option for ART service delivery as yet you do have very interesting information that does support it. And many countries, as you know, in Africa already have community ART options, as we have heard from your colleagues in the panel. So how soon does Tanzania expect to translate this into action? Thank you.
Thank you so much. That's a very good question. But so we are still working with the Minister of Health and other implementers in the country to see how best really to scale up the home delivery of ARVs. But so how the answer on how soon that I may not be able to answer, it's something that can be answered by the policymakers, but we try to do our best from our end to engage and to see if it can be taken on sooner.
Thank you, Joel, for attempting to respond to that difficult question. I think the ministry officials should be the right people to attend to that. Thank you very much.
Thank you.
So I would like to introduce our last presenter for this session. She's Sinead Dilani Moretlwe from South Africa. She's a clinical epidemiologist and associate professor and director for research at the Wits University.
Thanks very much for the introduction, and thanks very much to the organizers for allowing us to present our findings in a panel on differentiated service models. I'd also like to acknowledge my co-authors from ICRW, the London School of Hygiene and Tropical Medicine, and the Mwanza Intervention Trials Unit. So as many of you know, adolescent girls and young women are at substantially higher risk for HIV infection in the African region. Adolescent girls and young women aged 15 to 24 account for about a quarter of HIV infections, although they represent only 10% of the population. And they're also at substantial risk for gender-based violence, with about a third of women in their lifetime experiencing violence at the hands of partners, and even young women already experience these high rates of violence. What we know is that gender-based violence increases the rate of HIV acquisition. About a quarter of new HIV infections can be attributed to gender-based violence. And what we've learned from recent systematic review of reviews is that gender-based violence undermines the entire HIV treatment cascade, as well as PMTCT outcomes. What we're learning from PrEP trials is that violence might also have the potential to reduce PrEP uptake and continuation. And importantly, though, we have a growing body of evidence which suggests that it's possible to ameliorate gender-based violence within programmatic timeframes through an intervention such as community mobilization, empowerment training for women and girls, group training for men and women. All have been shown to be promising interventions to reduce gender-based violence. So it was within that context, as we seek to focus on achieving the Prevention 2020 goals for adolescent girls and women, and as we see PrEP being introduced into many countries in the region, that we wondered whether it would be possible to integrate an evidence-informed intervention that would respond to gender-based violence within the context of an HIV prevention setting, and specifically whether adherence clubs with a 4-session empowerment curriculum could enhance PrEP uptake and continuation. And we wanted to evaluate this in the setting of Johannesburg, South Africa, and Mwanza, Tanzania. In South Africa, Truvada had been licensed for PrEP since 2016, but in Tanzania, Truvada still remains to be licensed for the PrEP indication. So we set out to evaluate a PrEP delivery program for adolescent girls and young women. We enrolled them if they were 16 to 24 years old, HIV negative, sexually active, non-pregnant, had no renal or hepatic disease, and no immediate risk of harm. The risk of harm was assessed through a gender-based violence screening intervention, which was incorporated into HIV counseling and testing and presented by my colleague Manuela Colombini yesterday. Participants were then randomized, irrespective of their decision to take up PrEP, to either counseling and SMS reminders plus empowerment clubs, or counseling and SMS reminders alone. And this was because we really didn't have an idea of what PrEP uptake would be in these populations, and what we anticipated is that the effect of the clubs might also be to reassure people who may be interested in PrEP but wanted to learn more. We followed up participants at for an initial monthly visit, and then at month 3, and then quarterly thereafter, up to 15 months. At each of these visits, participants were screened for violence, had HIV counseling and testing, safety assessments associated with PrEP use, PrEP dispensing, and all of this was delivered as part of a comprehensive sexual and reproductive health package within youth-friendly services. We conducted a baseline and endline behavioral survey, and also conducted qualitative interviews at 3 time points with 25 participants in each site. And the primary outcome of interest for us was PrEP continuation at 6 months. Although we had participants who had follow-up longer than 6 months, in all sites we had continuation data up to 6 months, and that was because there was a time difference between the startup of the project in South Africa and that in Tanzania. So in terms of our analysis, our outcome was assessed as PrEP continuation based on pharmacy refills. Participants had been dispensed with drug for a specified visit interval, and those that returned the refill within that target time frame or with a window of about 7 days were counted as persistent. We censored those that had stopped taking PrEP for a medical indication, and there were about 40 of those in each group. And then we conducted, the primary analysis was an intent to treat analysis. So we compared differences in PrEP continuation at month 6. We also explored whether there was differential efficacy in population subgroups, and we also looked at associations between baseline characteristics and PrEP continuation, as well as club attendance. So in terms of the support for PrEP use amongst all participants received participant-centered counseling. This included, obviously, the gender-based violence screening and referral for care. At the initial visit, participants also went through a PrEP decision counseling where they received initial information. And the subsequent adherence counseling was based on a motivational interviewing approach that had been used in CAPRISA and the FACTS trial. We also included SMS one-way motivational messages and visit reminders. So the reminders were sent at the time of visits, but there were also interval messages sent that were both about PrEP use, but were also about other non-health related things, such as a happy birthday message. We built in community dialogues, at least 3 of those, and this was based on what we had learned from the importance of community mobilization for violence prevention interventions. And really, we focused on generating community discussion about healthy relationships and how PrEP and the absence of violence would be important for that. And as we went through these community dialogues, we learned that, in fact, there was very low knowledge of PrEP in the community, and so we invested a lot in creating PrEP demand creation materials that, one, responded to the need for information about PrEP, but also from an adolescent perspective, had a very sex-positive and empowering messaging. And in South Africa, these materials were very much designed along and influenced by the similar materials that were being used by the South African National Department of Health. So in terms of the empowerment clubs, the clubs were based on previously, the content was based on previously effective empowerment interventions such as Image or Stepping Stones or Sister, and we came up with 4 modules. And the clubs themselves were very much based on the experience of the ART clubs that you heard about earlier in the session, but they were included group-based participatory sessions. They were led by a trained peer facilitator, We aim to have them in a non-clinic venue. They took place approximately monthly. They were a maximum of 2 hours, and we plan to have 20 members in each club. As the study progressed, we also explored the option of running multiple sessions within a month and also lining up club sessions with clinic visits. So from October 2016 to July of 2016, we screened 619 women, and 431 were enrolled and randomized either to club plus the standard of care or the standard of care alone. The most frequent reason for non-enrollment was failure to complete screening and enrollment procedures within a specified time frame. So more than half of the participants actually didn't return within those time frames for that reason. And other reasons for non-enrollment were HIV infection, pregnancy, or other medical conditions. Importantly, as I mentioned, we censored participants who had a medical contraindication to using product, or we also censored those that were relocated where they wouldn't be able to access PrEP because of the distance of that relocation. So these are the baseline characteristics of the population enrolled. Both groups are fairly similar, as you can see. The majority of participants were South African. About a quarter were under the age of 20 years old. The vast majority of them were unmarried, and a third of them had experienced violence already in their lifetime. About a third of them had more than one partner in the last 6 months. Condom use was low in this population, and the majority were using contraception, but importantly, only about 15% were using combined oral contraception. 2/3 of them had never had a child, and another striking feature which seems to be common to many of these new PrEP programs in adolescent girls and young women is the high rate of curable STIs. The vast majority of these participants had a voice risk score above 5, and this risk score has really been shown to correlate with a very high risk of HIV incidence of above 5%. And about 8 out of 10 participants believed that PrEP would prevent HIV. So this graph summarizes PrEP uptake and continuation, and I think the key messages are that PrEP uptake in this cohort was incredibly high. 97% of participants accepted PrEP, but continuation at 6 months had declined to about 60%. Of interest is that participants who were less likely to continue were those that were married or living with a partner, or where they depended on their partner for a source of income, if they had 2 or more children, or they didn't think PrEP would prevent HIV infection. And then the key result, based on our intent to treat analysis, shows that there was really no difference at all between whether or not participants received the clubs or not in terms of their continuation. And we were very disappointed by this result, so looked at it in a number of ways, but I can tell you that there is no difference when we look at this in terms of the per protocol analysis, or when we stratify by subgroups, including age above or below 20, with a risk score above or below 5, or whether or not they'd experienced violence at baseline. And one of the reasons that we think that we saw no effect is that, as you can see from this graph, half of participants didn't attend a single session. And when we tried to explore reasons for this, there actually were no significant differences between those that did or didn't attend one or more sessions in terms of baseline characteristics. So there are probably other unmeasured factors. But when we looked in the qualitative data, what we heard from participants is that they forgot, or that they were too busy, or they had conflicts with their schooling, or the distance and time to the venue was too demanding, or in 1 or 2 cases, their partner influenced their participation. What we did learn as well from the clubs is that those who attended the clubs really benefited from the clubs. Participants talked in the qualitative interviews about learning new skills and knowledge. They felt empowered in relationships, and they developed a greater tolerance for difference, but also learned how to manage conflict. They were able to recognize violence in their own relationships and actually mobilize to escape from it. And they found enormous catharsis and self-expression in the clubs, with a real opportunity to share their lived experiences about using PrEP, but also the broader social context in which they lived. And this quote really summarizes the experience of participants overall in the clubs. So in summary, in this population, PrEP uptake was high, but it diminished with time, and it was not enhanced by empowerment club participation. The empowerment club participation, disappointingly, was low, and that's despite the fact that those people who did attend clubs really enjoyed them. So we think that this reflects particularly the busy nature of young women's lives. In both sites, there were either, in South Africa, many young women who were students or scholars, and in Tanzania, these were working women, and that it may be difficult to incorporate a club into your life, particularly when you have to come back frequently to the clinic. We also think that clubs might be more challenging to implement in large urban areas where social cohesion is lower and where groups are not necessarily formed in quite the same way as they might in more closely knit communities. And we also think that club cohesion might be more challenging to build in populations that are healthy and don't necessarily have a stigmatizing disease that might draw them together in the same way that the ART clubs might work. So we think in conclusion that really we need to consider alternative strategies to support PrEP continuation or alternative long-acting approaches to PrEP to really address the high levels of HIV as well as violence and harmful gender norms that are experienced by young women in South Africa and Tanzania. And I'd like to acknowledge the participants, the CABs and the communities, the study teams in both the countries, the partner organizations that supported us, and Gilead, who also donated drug to the study. Thank you.
Thank you very much for that interesting study findings. We'd like to open now the floor for discussion. We'll take one or two questions. Mic number 5.
So just a quick question. So in terms of both arms, the decline in PrEP use, what were the participants saying about why they took it up quickly and then declined? Was it the same sorts of issues that came up in not wanting to go to the clubs or not having the time?
So I think what we've seen certainly compared to South Africa is that uptake is much higher than any other population group. And we think that it's motivated by a couple of things. The one is that you notice that condom use was low in these populations. And so people are interested in an alternative to condoms. But the second thing is I also pointed out that use of oral contraception was low. So people don't have experience of pill taking. And we think that with young people, they may be naturally early adopters, but they don't often have experience with chronic medication, and they may have to go through that experience in order to better balance kind of their assessment of their risk against kind of their drive to use PrEP. And I think the second point is that we really do not have a good idea of what these seasons of risk are for young women, and so I think we're getting to understand a little bit better what that might mean.
Okay, we'll take the last question from mic number 8 at the back.
Okay, thank you for your presentation. I have a quick question. So you did the voice risk score, but did you also look at their own perceived risk? Because that actually influences whether they will take PrEP or not.
We did, and kind of the way that we attempted to address that was to present the data that showed kind of what proportion of people believe that PrEP would protect them against HIV. So in this study, what we were looking for a population that were interested in PrEP, and in some ways implied in that is that they recognized that they had their risk. But I think what we've also learned from other studies is that the measurements that we have to assess young people's risk are not optimal, and often their responses don't align with kind of their behaviors.
Okay, I know we've run out of time, but we'll just take one more general question, maybe to any of the past presenters. There was a lady who wanted to ask questions here. Please, we want to give you a chance to ask your question. Yes. If you still remember your question.
So broadly, I would look into, I'm an economist, so I would be very keen on understanding a little bit of the costing aspect of all those models. And a couple questions, particularly for different speakers, I will talk to them later.
Okay.
Yeah.
So you would want someone to respond to the costing question now or later? Okay. Thank you very much. So I'd like to take this opportunity to thank all the speakers. It has been really great to hear your study findings and experiences from the field. We've learned a lot of DSD models that are being implemented in different contexts. We have seen the feasibility of implementing these models within the public health setting. We've seen a high uptake and acceptability of these models, and the issue is probably sustainability of these models beyond pilots, beyond well-funded projects. We've seen non-inferiority of outcomes of those that are enrolled into these models. We would really want to see the extent to which these models lessen the burden within health systems. And we would really want to see more in terms of evidence that clients are actually benefiting from these models. And we actually saw from a study, for example, from Guatemala, that patients preferred certain locations and the waiting times were reduced, and they also expressed interest in terms of quality of the services that they provided. And therefore, patients' choices and preferences remains key in terms of allocating patients to different DSD models. And indeed, we noted that we need to have robust M&E systems for us to be able to track patients as they migrate from one DSD model to another. At this point in time, I would like to thank all the speakers and thank my co-chair for this very great session. Thank you.